Welcome to AETCM, the Emergency Medicine channel. Shall I?
Yes.
Today I'll be presenting a case of 60-year-old female who presented with complaints of fever, headache and altered sensorium to our ER. On 10-second assessment, patient was conscious but confused. On airway was patent, there was no secretions or gurgling. Coming to the breathing part, patient had a respiratory rate of 16 per minute with a saturation of 96% at room air. Air entry was bilaterally equal and normal vesicular breath sounds were present. Coming to the circulatory part, patient had a BP of 100/70 mmHg with a pulse rate of 88 per minute. Disability wise, patient had a GCS of E4, V4, M6 and pupils were equal and reactive to light. On temperature, patient was febrile and on checking GRBS, patient had a GRBS of 210 mg per deciliter. So as adjuncts to the primary survey, we had taken a CBC CRP point of care.
What are the problems of GRBS? We are taking every patient glucometer RBS. Is it fully reliable or you can anticipate some errors? Is it like your venous sampling?
There can be some errors in taking
What
the
are the
GRBS.
possibilities of errors? How can you get errors? How can
One
you
is-
reduce the errors?
One is before taking GRBS with a sterile, it should be the area should be made sterile. Then second is while taking GRBS.
No, that is okay. Sterility, you have to make sure that it has to be sterile. But what you have to do is after making it sterile, that fluid there, no, that is you have to wait for dry off. Okay. Otherwise, what will happen? That will dilute your sample. Okay, that you have to make sure. That is one area of error in the sampling.
Then while taking the sample, we shouldn't give more pressure and squeeze
So a
it
bold prick has to be done. So one drop should come out. That is the ideal way of to. But most of the time, what is happening is we prick with hesitancy. Our patient may take out his finger and a small prick, and you try to squeeze. When you squeeze, what will happen?
There will be lysis of
RBCs will break and more glucose will enter to this one, and it can become a error. Third one, what is the third man-made error in glucometer? Third one you may not know, the sisters will know, because there is a code in that strip. Okay, that code has to it has to be calibrated with your machine. Okay, that our sisters will do. But if you are handling the machine, all these things we have to make sure. Okay, so we have to calibrate that strip to the machine, or we have to see the code and use it properly. Otherwise also you can get error, or it will show as error. Okay.
Then coming to the adjuncts of the primary survey, we had done a CBC CRP point of care, and in that total counts came to be as 14,000 with a CRP of 304. HB was 12.4 and platelet was 387. At this time, we had also taken a VBG, and in VBG there was no electrolyte imbalance, there was no acid-base abnormalities also. Coming to the sample history, 58-year-old female who's a known case of diabetes and hyperthyroidism had complaints of on and off fever since last 1 week, and she was complaining of headache and multiple episodes of vomiting since last 3 days. She had developed
headache, vomiting, altered behavior. What is the first diagnosis will come to your mind?
First, we have to have meningitis suspicion. Symbol since fever is there, fever with headache and vomiting.
Headache, altered behavior, vomiting,
encephalitis.
Encephalitis, both are different. Meningitis is different from encephalitis. Whether bacterial or viral, that is secondary issue. Somebody is having altered behavior with headache, vomiting, there is a high chance of encephalitis than this one, second differential diagnosis. So encephalitis or meningoencephalitis. Okay, then IC bleed. Third one, migraine is also okay. Then ICSL, intracranial space occupying lesion. So normally space occupying lesion will have chronic process, but suddenly a bleed into a tumor can also have similar finding. Then head injury, like alcoholic patients, trauma head, they may not notice the injury. Okay, so that is also possible. Okay.
So this patient was complaining of headache and multiple episodes of vomiting since last 3 days, and also she has developed altered sensorium on the morning of the day of presentation to our hospital. So bystanders also gives a history of patient complaining of left-sided ear pain 3 days back, and for this she was evaluated in outside hospital. Initially she was symptomatically treated, and on developing altered sensorium they had gone back to that hospital, and from there MRI brain was taken. It showed no evidence of any infarct or bleed or intracranial space occupying lesion. It showed features of mastoiditis in left side. Hence the patient was referred to our hospital. And there was no history of blurring of vision or photophobia. There was no history of any seizures or limb weakness, no history of any trauma, no history of travel. And there was history of fever in all family members, and patient was the bystander for the family members, so hence the patient was in hospital since last 1 week.
Okay.
Coming to the allergic history, there is no allergic history. Medication history, patient was on metformin, glimepiride and saroglitazar. Patient was also on Tyronom 125 micrograms. Coming to the past history, patient was a known case of diabetes since last 6 years, and also known case of hypothyroidism. On examination, patient was...
You have to make sure that this patient is taking thyroid tablet every day. Okay, what will happen, suppose you don't take thyroid tablet and you are exposed to thyroid tablet for a long period, like maybe the patient is on thyroid tablet 10 years, suddenly because of fever or something he had missed the tablet, what will happen? So somebody is taking thyroxine tablet 125 every day. He develops fever, altered behavior. He is skipping the tablet, or bystander doesn't know whether he is taking or not. What will happen? Then he'll go to mixed edema coma. That is the issue. That is a problem of hypothyroidism on chronic replacement. Okay, so body is not producing at all, or depends on your external replacement. Suddenly, if you stop, patient will go to hypothyroidism. That's why any patient admitted with altered behavior or any illness to your ICU, if he is already having hypothyroidism, it is better to give a small dose first itself. Like you already know that this patient is on hypothyroid replacement, admitted to your ICU, can just give one more tablet without seeing whether he has taken or not. So normally what they tell is 25% of the like basic dose has to be hiked up in ICUs. Okay.
Coming to the general examination, patient was conscious but confused. There was no pallor, icterus, clubbing or lymphadenopathy or edema. On CNS examination, patient had a GCS of E4, V4 and M6. Pupils were equal and reactive to light. We could elicit neck stiffness in patient.
Okay.
But
where all you get neck stiffness?
If there is any meningeal irritation, we
meningitis.
can get
okay.
meningitis, SH,
subarachnoid hemorrhage,
then cervical spondylosis.
Cervical spondylosis. Then up to this MBBS student will answer. Now you have to tell.
Any meningeal irritation?
One more meningitis I am not asking. You tell another disease. Parkinsonism. Parkinsonism, you get neck stiffness or stiffness of everywhere. Then high degree fever, stiffness of neck, stiffness of all limbs. CK is elevated. What is it? NMS, neuroleptic malignant syndrome. They're all you get rigidity. Tetanus, you get rigidity, nuchal rigidity will be their initial phase. Then the rigidity will extend to your muscles, spinal muscles. For all these conditions, you can get neck stiffness. But classically, as an MBBS doctor, what neck stiffness means, it is meningitis. Okay.
And Brudinski's and Koenig's sign was absent in this patient. Other systems, respiratory system, normal vesicular breath sounds were heard. Coming to the CVS, S1, S2 was heard, and per abdomen it was soft and non-tender. So at this point of time, we were suspecting the patient to be having meningoencephalitis, because patient was having fever, headache, multiple episodes of vomiting, and on examination neck stiffness was present. So initially,
what is the heart rate?
Heart rate was 82 per minute.
Okay. There is no bradycardia.
No bradycardia.
Bradycardia and hypertension indicates what in this type of patients? Raised ICP. No.
Then, on empirical basis, we had started the patient on for a gram-negative coverage. We had initially given the patient ceftriaxone 2 gram IV stat.
How do you treat a patient of suspected meningitis in emergency room?
So
We are
usually,
suspecting, we don't know whether it is, but we are still suspecting it strongly that it is a meningitis and he is having a ear infection. Okay. So how do you manage?
meningitis is most commonly caused by gram-negative organisms, and
Meningitis is caused by,
in
mostly caused by
streptococcus,
gram negative another. It is gram positive
gram-positive.
cocci. It is the most common organism for meningitis is gram positive cocci. That keeping in that in your mind, how do you manage the case?
So
And you can get, like you told, gram negative also can be there. Ear infection, chronic ear infection, there is a high chance of gram negative infection. That all things are there. But in a normal setup, meningitis means gram positive. Okay. So how do you manage?
usually we give ampicillin can be given along with
That is an MBBS answer. You have to tell me how do you manage this case in emergency room when you are suspecting a gram positive cocci in the brain.
we can give if we are suspecting MRSA, then we can go ahead with vancomycin plus gram.
Everything is wrong. That is also wrong. I'll tell why it is wrong. What is wrong? What is wrong in their treatment? We are not. I am not. I am not talking about. We are not talking about antibiotic. First, we have to give steroids. That you have to tell. See, any doctor should give steroids as a first before the antibiotic. Why we are giving steroids before antibiotic?
Any capsule, if we are suspecting any capsulated organisms,
Commonest organism is a capsulated organism. So to prevent that
inflammation,
capsule,
usually when we give antibiotics, there will be capsular rupture. So in order to, so it can cause inflammation and
further
edema.
inflammation. So it can produce severe intense reaction in the brain. Just to prevent that, we are giving steroids. So first dose steroids should be given. Then after half an hour, you have to initiate the antibiotics. Then if it is not capsulated organism in your culture or in your gram stain, then you can stop it. If it is TB, you have to continue it. Okay, now you tell about antibiotic. So steroid should be given. That has to be dexamethasone. Dose can be 4 to 8 milligram IV stat. Okay, this is a must for all. Any patient come to emergency room, starting antibiotic anybody will do. Okay, you can start meropenem, you can forget everything, but that may aggravate the problem. So give a steroid first.
Then considering the antibiotics thing, you can go ahead with the ampicillin 2 grams plus ceftriaxone 2 gram IV stat. So that ceftriaxone gives a gram negative coverage and ampicillin gives the gram positive coverage.
Not only that, ampicillin can
it also covers the listeria also. If the age group is extremities.
So ideal treatment, if we see the first line drug will be vancomycin with ceftriaxone. If you give, see all the guidelines, it will be vancomycin with ceftriaxone. But considering the age of the patient, listeria is a possibility. So you can, if you want to cover that, you have to give ampicillin either along with vancomycin, or you can go with go along only ampicillin with the ceftriaxone. Okay.
Then considering in latest period, since there is resistance developing against ceftriaxone also, we can even hike up the ceftriaxone into meropenem, and also along with vancomycin also it can be given for patients. So in this patient, considering the patient was in hospital since last 1 week, and also patient has a history of mastoiditis, we had started the patient on vancomycin was given, stat dose was given, along with that ceftriaxone stat dose was also given.
First, what is the dose of ceftriaxone in meningitis?
Ceftriaxone 2 grams we give.
Again, I am telling, I am not taking a class for a MBBS student. What is the dose of ceftriaxone in meningitis? 2 gram BD is for adult dose. If it is a pediatric dose, you are supposed to tell per milligram per kg body weight. Especially in meningitis, we are not treating a usual case. What is the dose?
10 to 15.
Ceftriaxone. 75 to 100 milligram per kg body. That is the problem. See, if you treat the patient like a normal patient, you give ceftriaxone in UTI 1 gram BD. That is not correct. You have to give very high dose. That's why I am telling all these cases, like especially meningitis type of cases, you have to see the patient, you have to see the weight, then you have to calculate the dose, then only you should give. Okay. Not blindly 1 gram, 2 gram. That is not correct. Okay, so here 100 milligram or 75, minimum 75 to 100 milligram per kg body weight has to be given. So it may come like something like 2 gram TID. That much high dose we have to give. But you can see many doctors will give like UTI 1 gram BD. That is not correct. Okay, you have to give high dose. Like even meropenem meningitis dose is very high. Okay, 2 gram TID is the dose. Okay, if you calculate the dose, it will become like that. Because it has to cross the blood-brain barrier. Like if you give 2 gram only, some 1 gram or 500 milligram will cross to blood-brain. All the drug will not go to brain. Okay, so that we have to keep in mind. So the dose is very high.
Vancomycin 15 to 20 milligrams per kg we can give.
Okay.
That is given usually. TID doses can be given.
Okay.
Vancomycin. So initially we have given the steroid, then we have given vancomycin and ceftriaxone we had given. We had also given, considering if there is a possibility
So
of
there are
viral.
2 drugs you are talking. I am not talking about meningitis. There is something called as dose dependent killing and concentration dependent killing. Concentration, dose and time dependent killing and dose dependent killing. Dose is concentration dependent. In this vancomycin is which category? Dose or time?
Con-
It is a concentration dependent killing, whereas ceftriaxone time. Okay, so just imagine if you give, suppose you want to give 20 milligram per kg body weight vancomycin dose, can we give it as a single dose?
No.
This is a concentration dependent killing. So ideally, except in infective endocarditis, you can give it as a single dose. Nothing will happen because they are all concentration dependent killing. So high concentration you give as a single dose, that can kill the organism faster than time dependent killing. Whereas toxicity will not occur now. It is 24 hours you have to give. You read about the drug, you will understand. Except in infective endocarditis, you give it as a single dose, it will kill the organism. Whereas ceftriaxone, it is a time dependent. So there you can use the other method. Okay, whatever it is, normally doctors will not see all these things. They give it as PD dose. Okay, but you should know about this concentration killing and time dependent killing. Then you can treat the patient in a better way. But infective endocarditis is not like that. You have to give continuous coverage.
Considering any possibility of viral etiology, we had also given a stat dose of acyclovir.
Why you are thinking about viral etiology here? Why
Because
you are thinking about viral etiology?
history of hospital stay,
One answer is required. Why you are thinking about viral infection?
Family history is there. A group of all the members of the family had similar history of fever with COVID.
Why you are suspecting viral etiology here? One answer is enough. Huh? Here is bacteria, not virus. Altered behavior. Viral encephalitis. You need to know the basics. Viral encephalitis, bacterial meningitis. It can go to the either side, but it's a normal thinking pattern. Viral encephalitis. Viral fever will have altered behavior. Where viral infection of brain can have altered behavior, whereas bacteria normally produces meningitis, but afterwards it can spread to the brain and it can produce meningoencephalitis. Okay, so virus means altered behavior. So here you can suspect viral infection because she is having altered behavior. Okay, which virus you are suspecting?
Usually most common is HSV virus can cause
HSV 1 or 2?
encephalitis. 1.
1. 2, can it produce encephalitis? Yes or no? Huh? Skin only, but can it produce encephalitis? HSV1 produces direct invasion of brain and produce encephalitis. Whereas HSV2, like you told, it produces skin lesions and from it can produce aseptic meningitis. Sometimes aseptic. There is no actual invasion into the brain, but they can have immune mediated reaction in the brain and they can also have problem. Which area in the brain can be involved by this HSV1?
Temporal.
Okay. What will be the typical clinical finding?
In MRI, we can get T2 flare, hyperintensities can
so
be
that
there.
can be there. Okay.
Then
So nothing wrong in starting antiviral drug, but once you rule out your viral encephalitis by MRI or by LP, you have to stop it.
So then we had proceeded with an MRI imaging for the patient. So we had taken
Do you
an
suspect malaria in this case? Not in Kerala. Suppose you work in some northern states or some other area. The next differential diagnosis will be malaria because that is a commonest problem there. Okay. So high degree fever, altered behavior, falciparum malaria. So cocktail therapy in this encephalitis is well known. Okay, it is not given in books. You give gram positive coverage, you give gram negative coverage, you give antivirals, then you give antimalarials. But one by one, you have to stop everything. You rule out everything within half an hour to 1 hour. You can stop it. Okay. But in initial phases, if you don't treat, sometimes patient will become bad. Okay.
Then we had proceeded with the MRI brain with contrast in this patient. So we had taken an MRI and it showed features of left side mastoiditis with T2 flare hyperintensity in the bilateral medial temporal lobe. Other than that, there was no any features of intracranial space occupying lesions or
So temporal
bleed
lobe
or
involvement is
infarct
there
is
here.
there.
Okay. So you have to, you can even, still you can suspect viral encephalitis.
Then we had also proceeded with the LP in this patient. So
Okay.
we had done LP and the results came to be as a total counts of 1940 cells with 85% of segmented cells and
Neutrophils.
neutrophils. And the glucose was 72, serum glucose was 210.
It is low.
It's low. And then proteins was 186 and ADA was found to be 3.8. The
What is the use of ADA in brain?
Usually
It is useless.
useless.
It is not recommended. ADA in CSF is not useful at all, but in pleural fluid it is very useful. Okay. So no need to do ADA at all in this type of cases.
And the culture of the LP came to be as no growth.
Okay.
So along with this, we had also sent all the routine investigations.
So
and
what might have happened there? No growth. You suspect a bacterial meningitis, but you are not getting a growth. What might have happened?
Partially treated already. We have
Somebody
given
might have given antibiotic and cleared. So in that condition, which type of investigation will be helpful?
You can send for PCR.
PCR. Okay. But will the treatment alter the PCR?
No.
It will not alter. Okay. Why it will not alter? Why it will not alter? It's all basic things, no? Why it will not alter? It's not because of that. PCR will pick up even dead bacteria, cells or whatever genetical organism is available in the CSF. So even if they die, you get PCR positive. Okay. So PCR will be ideal for, like suppose somebody has treated the meningitis and if you want to investigate, then PCR will be a better tool.
So we had also sent the routine blood investigations and procal in this patient. So the procalcitonin of the patient came to be as 10.
So it is high.
It is high and it was indicative of bacterial infection. So we had stopped the antiviral in the patient. And then patient over the course...
HSV1 PCR was sent? No. Ideally we'll have to send it because we have temporal lobe involvement in the MRI. So HSV1 will be a good investigation. But since you have a mastoid involvement with meningitis, okay.
Then patient was clinically getting better over the second and third day, but patient's sensorium improved, but patient's headache was persistently present.
Okay.
So patient was chronically telling of the pain.
So what do you suspect then? You are having a, I'm not telling you have to do it in every patient. Somebody is having meningitis, you are treating the patient, but third day, fourth day, still patient is complaining about severe headache. What will you suspect?
You can go ahead with a repeat LP for the patient if even after 48 to 72 hours patient is not clinically improving.
She is telling LP can be done. That is correct.
Lesion is there. If there is any lesion like that, then there can be hemorrhage necrosis secondary.
Okay. So what are you going to see in the CT, hemorrhage necrosis? Or patient is complaining about headache. That is a problem. Raised ICP. So raised ICP can be seen. Then obstructive hydrocephalus should be ruled out. So CT, you have to look all these things. CT or MRI should be repeated. Okay, but we should know what to see in that. Okay, so like you told, bleeding can occur in viral encephalitis. That we had necrosis can occur. Then raised ICP, you can see sulci, gyre, everything will disappear. Then large ventricles. That is the finding you get in tuberculosis and most of the chronic bacterial meningitis. Okay.
So we had gone ahead with a repeat LP in this patient,
Okay.
and then on repeat LP, the cells came to be as 455. From 1900, it has come down to 455 with a protein of 45 and glucose of 54. This time the cells was 90% of mononuclear cells. It was showing.
So after treatment, after some days of treatment, the neutrophils will turn to mononuclear cells. Like it is so like if you see the tuberculosis, if you can do the LP in first few days of tuberculosis, it will be neutrophil.
Neutrophils.
Then it will become lymphocytes. Same like bacteria also. Initially it will be neutrophils, and then it will become lymphocytes. Okay. So it all depends on the time of the infection. Like viral, initially itself it will be lymphocytes.
And also we had done a HRCT with of temporal bone because of initial MRI showing features of mastoiditis, and it showed a chronic CSOM of left more than the right, and we had got an ENT consultation for that, and also we had gone ahead with Puritan audiometry because patient was having some hearing loss complaining. So in that bilateral mixed hearing loss was present, and they suggested for a mastoid exploration once the patient becomes stabilized. And we had since patient initial days we had just hiked the antibiotics to the meropenem, and then we had given a course for 14 days. And during that 14 days she was clinically improving all the.
When you're treating meningitis, you're starting treating with meropenem. Do you anticipate any problem, or do you want to revise the history in this patient? Anything you want to avoid? Any problem you anticipate? See, meropenem has got one problem. What is that problem? In meningitis or encephalitis. It is a good drug. It can act very well. It can reduce your meningitis. But there is a problem in that you should know that. That's all.
Blood-brain.
It will cross blood-brain barrier. That is why we are using it. What will happen to seizure potential?
It will come.
It decreases the seizure threshold. Okay. So if the patient is already having seizure, we have to be very careful. When you are starting high dose of meropenem, it can stimulate the seizure. That's all. Okay. But theoretically, it may be correct. But when we are treating, we don't see all these things, and the meningitis is coming down. The potential also will come down. But we should know that it can throw seizures.
Then over the course of time, 14 days IV antibiotics was given, and then patient sensorium also improved, headache also came down, and then patient was discharged.
Okay, so what else you want to do for the patient?
You should give a on discharge another course of antibiotics.
Antibiotic should be given because it is a chronic inflammation. You have to control it. Otherwise, again she will develop meningitis. Okay, then hearing. Permanently she may lose the hearing. Okay, and vaccination should be given. Okay, all patients like this, they can have repeated infection, so better to vaccinate against meningococcal infection. Okay, that's all. Anything else? So antibiotics are very important. Dose of antibiotics is very, very important in meningitis, and you have to read about time dependent and dose dependent killing. Okay. So you can treat the patient in a better way. Even if you give vancomycin BD, nothing is going to happen to the patient. But if you know that if you give a single dose as a like one time in 24 hours, it can effectively kill the bacteria. That's all. Okay.